Well, thanks to Dan and his team for helping me through the process. I think we've come up with a nice presentation, a balanced presentation of what's available in the literature, and when there isn't any literature, a little bit based on clinical experience. And thanks to each of you for coming. This is important work, as you know. So I don't have any commercial relationships. I'm strictly an academic person, and try to do my clinical work based on the published literature. Everything we're going to talk about today is off-label, other than the use of risperidone and aripiprazole for irritability, which has been defined by the FDA as aggression, self-injurious behavior, severe tantrums, and mood lability in children and adolescents with autistic disorder. I don't know how the FDA is going to deal with labeling with the change of DSM-5, so that would be a discussion that we'd come up with no answer at this point. We decided to proceed along the lines of target symptoms, as we were discussing somewhat yesterday, rather than being diagnostic-based, using the kind of symptoms that we all identify and treat to improve the quality of life of people with intellectual disability. And these are the ones that we've thought about over time in sort of the academic way when we write about these things. And certainly the first three we've been thinking about for quite a long time. You'll see as we get to 4, 5, and 6 that there's very limited published controlled data in any of these areas, even though if you read the textbooks it says people with intellectual disabilities are likely to have more anxiety and mood disturbance than typical people. There's essentially no published placebo-controlled data. And we'll start with the first, motor hyperactivity and inattention. And the different categories of medicines that I'm going to show you data about are these: psychostimulants, atomoxetine, and alpha-2 agonists. Start with psychostimulants. So if you were a relative novice to this, you'd say, well, this is an easy category to cover. We'll just talk about psychostimulants for ADHD and ASD, or intellectual disability, and we're done with the discussion. And right away, we learn that this is where response to drug is radically different in people with developmental disabilities compared to typically developing peers. This is by far the largest published controlled study of a psychostimulant in ASDs, and essentially one of 2 that are even available. You may have heard about the RUP network. It's an NIMH-sponsored multi-site network of sites that study drug development in children and adolescents with ASD. And this was the second study that the group addressed, and this included 72 children, which in many ways isn't a huge sample size, but it's by far the largest sample size of a study focused on a psychostimulant. And these folks had, at the time, these were DSM-4 categories, but they're essentially what the DSM-5 includes now: autism, Asperger's disorder, and NOS. When you do a drug study, it's important to identify a target symptom. And for a number of years, we didn't do that. We just said, we're going to try this medicine in autism, not knowing, because we didn't know what it would even help with. Over time, we were able to say, we think this might help with ADHD symptoms. And you set a threshold. You have to have a certain degree or severity of symptoms to even get into this study. So it's as homogeneous a group as we could come up with. And we knew clinically that a number of these guys were going to have adverse response to a stimulant early in the treatment course, maybe even after a dose or 2. So we had a 7-day test dose period where they received 3 different doses of methylphenidate and placebo in a randomized blinded way, because we wanted to exclude subjects that wouldn't tolerate even a dose or two from the formal study. And then if they made it through that phase, they had entered a 4-week controlled study. Each week they would get either placebo or one of the 3 doses of methylphenidate in a randomized manner. So during the test dose phase, about 10% couldn't tolerate at least 2 of the doses of the drug that they received in a blinded manner, were excluded from the study. 16 of the remaining subjects couldn't tolerate the highest dose among the 3, but we included them in the study, and then in the formal study they just were never randomized to the highest dose. And usually it was because they became irritable, so the symptoms they presented with became worse. Then they entered this 4-week crossover phase. 7 additional subjects dropped out of that phase due to side effects. And when we looked at the efficacy of the drug for these symptoms, we tend to use this scale quite a bit in treatment studies, the Aberrant Behavior Checklist, which is a parent-rated scale that includes 5 subscales developed by a man named Mike Amon. And there's a subscale for hyperactivity and noncompliance. And we had teachers and parents rate on this scale, because we know that hyperactive symptoms can differ in different settings. And on the ABC hyperactivity subscale, drug was better than placebo for teachers and for parents. There was a worsening of social withdrawal, which is another of the subscales of the ABC, at the highest dose of methylphenidate. And we had known clinically and from prior studies that social impairment, social withdrawal, can worsen with the stimulant. We also knew that repetitive behavior at times can worsen with the stimulant. So we were kind of looking across to see what not only what might get better, but what might get worse. There was no drug-placebo difference for repetitive behavior or irritability in the end. One of the hopes or goals of the study was to say, well, we know that clinically some of these guys seem to do pretty well on a stimulant. Maybe not most, but who are they? Can we help to identify who the subgroups might be? So we looked at age and IQ and diagnosis. None of these things moderated response, other than almost diagnosis. There was a trend for diagnosis to be related to treatment response. And the subjects that were, quote, higher functioning, if you will, Asperger's disorder and PDD-NOS, were more likely to respond to, actually, to respond in general. But what was interesting is that here's the Asperger's NOS group. It's a small group among the total, but if you look at the rate of response to everything, placebo, low, medium, and high dose methylphenidate, it was overall higher than the rate of response to kids with autism alone. But what's interesting is there's no drug-placebo response difference in the higher functioning group. So even though overall they were likely to respond to a greater degree, it was just as likely to be due to placebo as drug. If you look at those with autism, the drug-placebo difference is significantly different despite the overall rate being lower. So maybe a quarter of kids with autism, is the way we kind of think about it, will respond, but it will be more likely to be a true drug-placebo response difference versus a placebo response. When you look at the results altogether, they were interesting in that about half of the subjects responded to at least one dose of methylphenidate, one of the dose types. You all treat a lot more ADHD than I do, straight ADHD, and this is quite a bit lower than what you might see in a child with ADHD. So that's kind of, we were actually surprised that it was this high. Almost 20% dropped out of the study due to adverse events, usually irritability. And this is also a much higher rate of not only side effects, but dropping out of the study than you would see in a study in typical children with typical ADHD. What about atomoxetine, which you know is a selective norepinephrine uptake inhibitor? It's been out quite a while. It's FDA approved across the lifespan. This is the largest published double-blind placebo-controlled trial of atomoxetine in ASD, specifically for ADHD symptoms. It's an 8-week study. This is a pretty good sample size. It's from a group in Holland that's done a lot of good work in ASD. Almost 100 subjects. Here's the age range, average age, and IQ, a relatively higher functioning group. Three-week titration phase, moving up on the dose of the drug to a pretty solid dose of atomoxetine toward the end. And the primary outcome measure being the ADHD rating scale, which is a clinician-administered rating scale. And this shows you some of the results. So equal distribution to drug or placebo, randomized in a blinded manner. And this is the total ADHD rating scale score, and then broken down into the subscales before and after 8 weeks. So here's the drop with drug, here's the relative no change with placebo, significant difference. Here's inattention, and here's hyperactivity. So you see that there's a bigger effect with hyperactivity than inattention, although overall it's quite different, drug and placebo. In my experience, inattention is one of the most difficult symptoms to treat in ASD. Hyperactivity is easier. We really don't know what inattention is in ASD, because if a child's doing this, it could be for all kinds of different reasons, I think. So I think that's a bit of a difficult one. This is looking at the CGI. So you all know of the CGI, the Clinical Global Impression Scale for Improvement. And this takes into account everything, the rating scales in the study, the observations of the clinicians, the input of the family, input from teachers. So it's a global measure of change. And this is the range of the scale. You could be unchanged. You could actually be worse at the end of the study or better. And the two categories that we usually use to designate response to treatment are the top two. Much improved or very much improved, you're a responder. So if you look at drug and placebo, you can see that there's in the direction of drug being better than placebo along these lines. But when they looked at it statistically, there was no significant difference in global outcome, even though there was on the specific rating scale. This is adverse events with the drug. These are the only 3 among a number that were statistically different: nausea, decreased appetite, and early morning awakening. And in the side effect assessment, this doesn't mean that these persisted throughout the study, but they were there at some time in the study. Usually these are going to be seen earlier on in the study, and then they don't persist. That's one area that the research field doesn't do a good job with yet, is letting you know how the side effects proceeded over the course of the study. So in summary, hyperactivity we were able to treat hyperactivity better than inattention. This is in general in ASD, I think it's true. Effects on hyperactivity and inattention in ADHD with atomoxetine were equal. So in ADHD, the drug did a pretty good job for inattention, unlike ASD. And if you look at the magnitude of change on this scale in ASD compared to ADHD, overall the magnitude of the change is less. So similar to what we saw in the MPH study, if you will. A couple questions that came to mind for me about this study is 8 weeks long enough? Maybe. It's not bad, but if they'd gone 12, you might see a different outcome. And the dosing in ASD, I hope you agree with me, is often different than in non-ASD typical ADHD and the other disorders we're going to consider. And I usually start extremely low, and you're going to see that in my recommendations. You might think it's too low, but there's almost, in my opinion, never too low a dose to start with. Otherwise, you start moving up quickly and you have adverse events, and that drug is determined to not have helped. And you quickly you don't have many left. So I don't think there's anything wrong with, as we always say, start low, go slow, but we don't really always do that. So I think this is actually too high a starting dose, in my opinion, and they ramped it up to the highest targeted dose within 3 weeks. That's really quick, just in the way I practice. So something to think about. And the final group, alpha-2 agonists. There's not as much published in this area. This is a small, double-blind, placebo-controlled study of transdermal clonidine, a patch from long ago, 1992. It's a crossover study, so 4 weeks of clonidine or placebo, and then the opposite. Only 9 subjects, wide age range. And clonidine was better than placebo for social behavior, and this is kind of really almost like irritability, and this is in a way almost like repetitive behavior on this scale. Clonidine better than placebo on the CGI. Prominent side effects, not surprising to you, sedation and fatigue. This is the other small controlled study of clonidine. This is oral clonidine. Again, a crossover, 6 weeks of drug or placebo, only 8 subjects. Here's the mean IQ. Clonidine increased over 2 weeks to about up to 0.2 milligrams per day, so a relatively low dose considering it's divided into 3 doses. Parent and teacher ratings found clonidine better than placebo for these symptoms in this group, but the blinded clinician ratings showed no drug-placebo difference. Again, we saw sedation, and in this case, a little bit more hypotension, reducing the blood pressure, which are the 2 most prominent side effects with this drug. So that's all the controlled data with clonidine. There is no published controlled data with guanfacine to speak of. So this is the most systematic study, and open label prospective, 8 weeks. It's interesting that these are the subjects that came out of the RUP MPH study that either hadn't responded to MPH or didn't tolerate it. So in many ways, they're a more refractory group, if you will. 25 subjects, here, a little bit lower IQ. There's what I just said. Okay, so we tried to start low based on weight and increased by that amount every 4 days. This was the maximum dose based on these weights. Now, we never got to that high a dose. And again, if you look at the ABC hyperactivity scale, here's the drop pre-post after 8 weeks, irritability pre-post, social withdrawal pre-post, stereotypy. Again, remember there's no placebo control in this phase. 48% were considered responders, again, among relative, at least MPH resistant patients. And similar side effects, a little bit more irritability, some sleep problems. Constipation is something I do see commonly on a clinical basis with clonidine. So no published placebo-controlled study of that drug. I will tell you that there's currently a placebo-controlled study of extended release guanfacine that the RUP group is doing, and I think we're into maybe 45 subjects so far, so that data at least will be coming.